So hello everyone. So welcome back for the next session on same obstetrics and gynecology topic. So today's topic, we'll see what it is. So, the first topic is related with the menses, like why menses is not happening. So the question mark there refers, in the picture refers that the menses usually what was happening or it has never happened. So the topic is amenorrhea. And then the next topic related to this is contraception. So these are the two topics that will be discussed in this session. Amenorrhea and contraception. So the aim of the session is to study about amenorrhea and contraception, and the objectives for the session is we'll start with amenorrhea. So to define amenorrhea, to know before knowing what is amenorrhea, we have to know what is a normal menstrual cycle. What are the factors that are responsible for the onset of menses? So those factors we'll be discussing. Next would be what are the types of amenorrhea, and then in that types there comes physiological and pathological. So first we will deal with physiological amenorrhea, and then to describe about physiological amenorrhea, then followed by to describe about pathological amenorrhea and to list the types of pathological amenorrhea. And in those types comes cryptomenorrhea, primary amenorrhea, and secondary amenorrhea. So initially we'll be discussing about cryptomenorrhea. So what is cryptomenorrhea with respect to its cause? What are the etiological factors for cryptomenorrhea, and what is the pathophysiology? What is the clinical features related to cryptomenorrhea? And after that we'll be discussing about primary amenorrhea. So to describe about primary amenorrhea with respect to its definition, its etiology, its investigation, diagnosis based on clinical features like clinical examination. When the patient comes to you, like how will you diagnose, like which cause, what is the cause for this primary amenorrhea, and how will you investigate further? That we'll be discussing. And after that, types of primary amenorrhea based on the investigation. So you have to come to a conclusion whether this is a type of primary amenorrhea or what is the cause. So because the management conventionally deals with the cause of the primary amenorrhea. So if you have to treat primary amenorrhea conventionally, their management is based on what is the cause behind it. So our homeopathically also we should know what is the cause behind primary amenorrhea. And then secondary amenorrhea we'll be discussing, and to describe secondary amenorrhea with respect to definition, etiology, and the common causes. What are the common causes that come up for the reason for secondary amenorrhea and the investigations? So this is the first part, that is amenorrhea. Next we'll be discussing about contraception. So contraception is a frequently asked question in Aiapget and all other competitive examinations. So contraception with respect to the definition, with respect to the various methods, what are to list the types of methods of the contraception, and then which is the effective method. A frequently asked question in the paper is which is the effective contraceptive method, that we'll be seeing. And then what is the interval and the time of insertion, or whatever contraception methods are there, what is the best time for use it, and contraindications, indications. All these are the questions that will be framed in the exam part. So we will be discussing that. So first, let us go to our first objective, that is amenorrhea. So what is the definition of amenorrhea? So as we know the topic amenorrhea, here if we see, this is A, meno and oria. So if we see the word meaning, oria means discharge, meno means menstrual, so menstrual discharge, A means absence. Okay, so this is nothing but absence of menstruation. Okay, so this is the word meaning. So the definition is absence of menstruation, and physiologically, if you see, it can be before the reproductive age, that is before puberty. We don't a girl doesn't have menstruation. So that is physiological. Pathologically, the definition goes that absence of menstruation during the reproductive life, that is after menarche and before menopause. So this is the definition. And it is a symptom, it is not a disease, because there are various number of conditions that is the cause for this amenorrhea. So it is not a symptom. You cannot write a diagnosis that it's amenorrhea. You have to diagnose the cause behind that. And then prevalence of pathological amenorrhea is 3 to 4%. every female should undergo this physiological amenorrhea, that is before puberty, that is and after menopause. And there are two other conditions also where this physiological amenorrhea is seen. Let's see what it is. The factors for onset and continuation of menses. So when we learn about these, we will know a problem with these may be the reason for amenorrhea. So what are the factors? First is normal female chromosomal pattern should be there. A female should be phenotypically and genotypically female, right? So that normal female chromosomal pattern should be there. Next is coordinated HPO axis. So like we discussed in the menses chapter, in the puberty chapter and the physiology of menstruation, very important is this hypothalamo-pituitary ovarian axis. Without the coordinated, without any disturbance anywhere, whether it is hypothalamus or pituitary or ovarian, it disturbs the entire female menstruation physiology, entire female genital tract physiology it disturbs. So this is very important. It should be normal. And then anatomical presence and patency of outflow tract. So whatever anatomy, female genital tract anatomy and menstrual flow. So amenorrhea means there is no menses. So for the menses to pass, to flow, the outflow tract, that is the vaginal opening, should be intact, that is patent. And responsive endometrium. We all know this HPO axis and endometrium is related. So endometrium, we know there is proliferative stage, proliferative changes and secretory changes. And these are responsible for the menses to happen normally. So endometrium is a very important part and it should be responsive for the hormones. And this proliferative and secretory changes occurs because of hormones. So because of hormones, and when there are disturbance in the hormones, it relates to the HPO axis. And if there is the hormones are normal, but the endometrium is not responsive enough to take up the hormones, then it is the error with the endometrium. And next is support of thyroid and adrenal glands. Here also hormones plays a very important role. So when all these are there, these are the normal things, normal factors responsible for menses. You know, normal female, if menses is occurring every month and it is very normal within the range, whatever it is mentioned, then all these factors, that means all these factors are normal. But if it is amenorrhea, that means the lady is not getting, the female is not getting menses, then the cause behind, the etiology behind would be any one of it. Any one of these five would be the cause behind. So let us further move. Next, types of amenorrhea. So this you can see, the types broadly classified into physiological and pathological. And physiological is again classified into primary and secondary. And primary is before puberty. That means she's never had menses. That is physiological. That means only after a menarche, a female will get menses. So that is normal. So physiological, you should understand here it is normal. Okay. And secondary, the meaning here is that already she's having menstrual cycles. But physiologically, there are few conditions where the menstrual cycles do not come. First one is pregnancy. And second one is lactation. Lactation also not 100%, we will be discussing. And under what conditions lactation, it is complete amenorrhea. And following menopause. So these are normal. In a normal female, this should occur. And it is bound to occur. So that is physiological. Now pathological is abnormal. So there is some abnormality. As we discussed in the last 5 factors, there is some abnormality in those 5 factors, which is the reason for these pathological amenorrhea. And pathological amenorrhea is divided, again classified into concealed and real or revealed. Concealed means the menstrual flow is concealed. It is not coming out. So here it is also called as cryptomenorrhea. We'll be discussing what it is. And in that, the causes can be congenital or acquired. And in real amenorrhea, again, it is classified into primary amenorrhea and secondary amenorrhea. So we'll be discussing in detail all these. Now coming back to physiological amenorrhea. So here you can see menses, pregnancy, lactation, and menopause. So what is the reason? We'll see. So in physiological amenorrhea, before puberty, there are pituitary the factors that act upon is pituitary gonadotrophin, that is growth hormone is not adequately released, and then because of that there is no steroidogenesis, and because of that there are no hormone production, so estrogen levels are low. Because of that there is no bleeding. This is the main reason for the amenorrhea before puberty, why it is not there. Next is during pregnancy. Again here, estrogen, chorionic gonadotropins act on ovaries, and ovarian follicle maturation is not happening because there is no enough estrogen here. And then that is why during pregnancy there is no ovarian follicle maturation, and that is why there is no, if the ovarian follicle maturation is not there, then there is no Graafian follicle. If Graafian follicle is not there, there is no ovulation. So ovulation is the main reason where the secretory changes happen in endometrium, and then there is bleeding. So that is not happening during pregnancy. And during lactation, prolactin is one hormone which is very important. So this is the hormone which has a negative feedback mechanism, and FSH is increased and estrogen is reduced. So when this happens during lactation, there is no menses. And a condition in lactation, that is, there is no 100% guarantee that during lactation you will not have menses, and that is no breastfeeding. The female is not breastfeeding. If she is not breastfeeding, in 40% of females, menses will occur with 6 weeks of delivery, after 6 weeks of delivery. In 80%, menses will occur after 12 weeks of delivery. And then during breastfeeding, that is, the female is breastfeeding, normally breastfeeding, menses is suspended only in 70%. So this is important in our contraception chapter, because counseling becomes important for a couple. So few are in a myth that if lactation is happening, it is a method of contraception. Yes, it is a method of contraception. Lactational amenorrhea is a method of contraception, but it is not 100% effective, because only 70% of females, only in 70% of females, the menses is suspended. Okay, during menopause. So what happens during menopause? There is no responsive follicles. As we know, menopause is a hypoestrogenic state. The estrogen is low. There are no follicles remaining in the ovaries. So because of that negative feedback mechanism, again, gonadotropins are high, FSH, LH is high, estrogen is low, and hence there is no maturation of follicle, and there is no menses. So this is the mechanism behind physiological amenorrhea. Now we'll come to pathological amenorrhea. Here you can see hematometra. Metra means uterus. That hemato means blood. So blood in the uterus. Hematosalpinx. Salpinx means fallopian tube. Hemato again blood. And hematocolpus. Colpus means vagina. And hemato again blood. So there is blood in uterine cavity, in the fallopian tube, in the vaginal canal. But it is not coming out. It is not coming out. Here there is some obstruction. And what it is? The condition is called cryptomenorrhea. We will see what it is. And then next is primary amenorrhea. Here you can see absence of period even after 15 years. So here it is pathological. That means the girl or the female should have got the menses normally, but she is not got. Then we will see what are the causes for that. Secondary amenorrhea is, as you see, the calendar. That means she knows when she is supposed to get the menses. That means she has experienced cycles before. She has got normal cycles before, but now she is not getting it. So that means that is secondary amenorrhea. So she's got normal menarche and she's experienced normal cycles, but after a point she's not getting the menstrual cycles normally. There is no menses. So the causes are n number of causes are there. We will be seeing in detail what it is. Now coming to cryptomenorrhea, it is a pathological concealed amenorrhea. So it is not a revealed amenorrhea. You should remember, it can be a question for Aiapget. So it is a concealed amenorrhea. Periodic shedding of endometrium and bleeding is there. Here, the normal menses is occurring. Menses is occurring normally. The problem is with the genital tract. There is some obstruction and the blood is not able to flow out. So menstrual blood fails to come out of genital tract because of obstruction. Now, what are the causes for these? As in the previous slides, we saw congenital cause and acquired cause. Congenital cause, imperforate hymen. So this is one of the question. Most common cause for cryptomenorrhea is imperforate hymen. So just remember, imperforate hymen is the most common cause, common congenital cause for cryptomenorrhea. And then the other cause is transverse vaginal septum, atresia of upper 1/3 of vagina and cervix. Now, acquired causes are cervical stenosis. Why? Because of, it can be due to amputation, due to deep cauterization, due to conization. And secondary vaginal atresia, neglected and difficult vaginal delivery, where this occurs. So this is cryptomenorrhea is altogether related to the vaginal tract, the outflow tract obstruction. Now, what is the pathophysiology behind that? Now, if the site of obstruction is lying below, low down of in vagina, so it's below the vaginal canal, then what occurs? Hematocolpus. That means vaginal canal, the blood is filled. Then hematometra, the blood is going to fill in uterus, and it goes up to the fallopian tube. And if this site of obstruction is in the cervix, this is X, and then what happens? It doesn't go till the colpus. Hematocolpus is not seen. Only hematometra, that is in the uterus, and hematosalpinx, that is fallopian tube, is seen. So hematocolpus, one more condition what you can, what the female will experience is, because of hematocolpus, there will be elongation of urethra. It acts on the urethra, and then there is urine retention. So in cryptomenorrhea, you can see also urine retention. So the clinical features, what is the presentation? The first presentation is amenorrhea, obviously, because amenorrhea is not a disease, it is a symptom. And then it is usually, if it is a congenital cause, it is usually seen, otherwise also in 13 to 15 years of a female. And there is no menses, but the female experiences periodic lower abdomen pain. There are cramps, but no menses. Hematocolpus, again, as we discussed earlier, urinary problem, so there is urine retention. And then abdominal examination will reveal that there is a uniform globular mass in the hypogastrium. And vulvar inspection will reveal bulging hymen. But because the blood is filled there and it is causing a pressure, but the blood is not coming out. And then rectal examination again will reveal fullness of vagina and uterine mass. And the treatment here, usually treatment is cruciate incision of hymen. So the hymen is incised and the drainage of blood is done. Cervical dilatation is done in cases of stenosis. If cervical stenosis, the secondary or causes, acquired causes as one of the causes, cervical stenosis, in that cervical dilatation is done. One careful thing that is followed here in the cruciate incision of hymen is blood is allowed to flow on its own. They will not apply, or a gynecologist will not apply any pressure when the drainage of blood is happening, because if the drainage is happening and the pressure is applied, there are chances that the blood or the endometrial tissue, the menstrual product, it can go and settle in the peritoneum, which later on will be a result of endometriosis. So one of the complications of this incision of hymen is this endometriosis. So one careful thing which they will be doing is not put pressure when the drainage of blood is happening. Next, primary amenorrhea. So this completes cryptomenorrhea. And now we come to primary amenorrhea. So here you can see absence of period even after 15 years of age. So definition is, again here, there is no menses. And young girls not yet menstruated by her 16 years. That means no menarche. There is no menarche. So no delayed menarche. This is not delayed menarche, but this is complete absence of menarche, because the upper age limit is 15 years. If the girl gets by 15 years, we can call it delayed menarche, but usually associated with delayed amenorrhea. And lower age limit is usually, lower age limit for menarche is 14 plus secondary sexual characters absent. If the secondary sexual characters are absent, then by 14 the girl should get menses. And but if the secondary sexual characters are present, then the girl can wait until 16 years. Now you can get a girl as a patient that there are secondary sexual characters present, but the menses is not seen, and the girl might be coming to you at the 14 years of age. Then the suggestion is just wait so that until 16 years, if she's not getting menses, then we have to investigate whether it is primary amenorrhea. So after 16 years, if the menses is not occurring, then that is primary amenorrhea. So the etiopathogenesis is there are various conditions related to these. So first is hypergonadotrophic hypogonadism, which is the maximum 43%. And just remember here, the factor that is responsible is mostly ovarian factor. Ovarian factor, hypergonadotrophic hypogonadism. Next is developmental defect of genital tract. There is some problem in the genital tract congenitally. So that is 30%. Hypogonadotrophic hypogonadism. The hormones here also plays a role, but here the main which is responsible is hypothalamus. In hypergonadotrophic, it is ovarian factors usually, and in hypogonadotrophic, it is usually hypothalamus. And abnormal chromosomal pattern, as we saw initially, what are the factors for normal menses? Normal chromosomal pattern should be there. So if there is abnormal chromosomal pattern, there is primary amenorrhea. And then dysfunction of thyroid and adrenal cortex. And metabolic disorders, few metabolic disorders are responsible for primary amenorrhea, and systemic illnesses also. And unresponsive endometrium. So the 5 factors which we discussed in the first slides itself becomes the etiopathogenesis. The abnormality of those 5 factors itself becomes etiopathogenesis for primary amenorrhea. Next, first one by one we'll be seeing hypergonadotrophic hypogonadism. So there is, as I told you, it is mostly related to ovaries. So there is primary ovarian failure, or there is resistant ovarian syndrome. These are the causes for these. And then galactosemia, and then enzyme deficiency. There is something called 17-alpha hydroxylase deficiency, and there are other factors which are responsible for hypergonadotrophic hypogonadism. Next is developmental defect of genital tract. That is 30%. Here, there is Mullerian agenesis or dysgenesis. And there is imperforate hymen. And then transverse vaginal septum. Atresia of upper 1/3 of vagina and cervix. Complete absence of vagina. There is no vagina at all. So, there is no menses, and absence of uterus in Mayer-Rokitansky-Kuster-Hauser syndrome. So Kuster-Hauser syndrome. So this is one syndrome where the uterus is not at all there. So these are the causes for a few causes for primary amenorrhea. Next is hypogonadotrophic hypogonadism. 27% of primary amenorrhea relates to these causes, which are those delayed puberty and hypothalamic and pituitary dysfunction. So here it is in the HPO axis. In hypogonadotrophic, it is HP, and in hyper, it is O. And then there is something called Kallmann's syndrome, and then CNS tumors. These are all CNS tumors, Kallmann syndrome, all are related to, Kallmann syndrome is related to growth hormone, gonadotrophic releasing hormone. So, and CNS tumors, all this is related to the hypothalamus and pituitary. Next is abnormal chromosomal pattern. So first one is Turner syndrome. Various mosaic states, various other different types of states of chromosomal patterns, and pure gonadal dysgenesis, androgen insensitive syndrome. It is also called as testicular feminization syndrome, and then partial deletion of X chromosome. These are the abnormal chromosomal patterns. Next, other causes are dysfunction of thyroid and adrenal cortex. As we discussed earlier, thyroid and adrenal glands are important for normal menses to occur. So in that, it can be adrenogenital syndrome, where there is excess secretion of androgens, which prevents the normal menses. And then cretinism and metabolic disorders such as juvenile diabetes, systemic illness such as malnutrition, anemia, weight loss. Weight is a very important factor in amenorrhea. So once a patient or a girl comes with amenorrhea, we have to assess for the weight, whether she has lost weight, weight loss is happening, or whether lot of weight gain is happening. And for both, there are various other reasons, but weight is an important factor in amenorrhea. And tuberculosis and unresponsive endometrium. Because of congenital, it can be uterine synecia. So these are the causes. Now, how do you investigate a primary amenorrhea case? The first one is, so here the most important thing is, first we see for secondary sexual characteristics. Normal secondary sexual characteristic is present. Then what happens? We will go for ultrasonography to know whether there is any defect in the uterus, vagina, in the female genital tract, MRI or laparoscopy. So the ideal will be the ultrasonography. And when ultrasonography is done, it is seen that uterus is not there, uterus is absent. And if uterus is absent, then karyotyping should be done, because the cause can be due to the chromosomal abnormality. So when karyotyping is done, it is normal, then the cause is Mullerian agenesis. But in the karyotyping, it is seen that it is XY, then it is androgen insensitive syndrome, or testicular feminizing syndrome. It is also known as that. Now, this is the case when uterus is absent. Now, uterus is present. USG is done, uterus is present. So, but it is seen that there is outflow tract obstruction or anomalies. So here, what we see, here we will treat those cases, those abnormalities, whatever it is there in genital tract abnormalities, that would be treated. Now, after, when uterus is present, but it is normal, and uterus is completely normal. When uterus is normal, the next assay will be of hormonal assay. So here, what is done? FSH, LH, TSH, prolactin estimation should be done. So hormonal assay is done only after the ultrasonography in case of normal secondary sexual characteristics. So this should be done. If patient comes to you, don't send for hormonal assay immediately. First, send the patient for USG, followed by that hormonal assay. And in hormonal assay, FSH, LH is low or normal, then it is physiological delay and hypothalamic causes are the reason. Elevated LH FSH ratio. So this we see in PCOS. PCOS is one of the common causes of secondary amenorrhea and also primary amenorrhea. And then FSH, LH, TSH, prolactin. In that, FSH is high, LH is high. So here it is premature ovarian failure, resistant ovary, gonadal dysgenesis. So when the gonadotropins are high, then the problem is with the ovaries. So premature ovarian failure, resistant ovarian gonadal dysgenesis. And if TSH is abnormal, the case could be hypothyroidism. The amenorrhea could be due to hypothyroidism or hyperthyroidism. And if the prolactin is high, then the reason it could be hyperprolactinemia. It is a rare condition. And if that is there, you have to see for any tumor, prolactinoma. So then MRI or CT scan is to be done to rule out any tumor. Now, this is the case if it is normal sexual characteristics. Now, secondary sexual characteristics. Now, there is poor or absent secondary sexual characteristics. The patient is coming, you observe clinically that the secondary sexual characters are absent or poor. In that case, we have to analyze for height. Height is an important factor here. And if the height is normal, again, send it to hormonal assay. And if hormonal assay, if it is low or normal, then again, here it is Kallmann syndrome, something problem with the hypothalamus and pituitary. So physiological delay due to Kallmann syndrome. And here also CT and MRI is done to exclude CNS lesions, because CNS lesions could be a cause for this hypothalamic and pituitary problems. And now if FSH and LH is high, very high, because the secondary sexual character is poor. So something related to the karyotyping should be done. Something related to chromosome it could be. So here the karyotyping is normal, then it is primary ovarian failure, resistant ovarian gonadal agenesis. But it is not normal, then it is gonadal agenesis. Now the short stature. Less than 60 degree, or for the height, ideal height, the person is 60 degree less. And here what should be 60 inches less. So what should be done here? FSH, LH is again assay is done. Hormonal assay of FSH, LH is done. If it is low, if the patient is short and FSH, LH is low, then the problem is hypothalamo-pituitary dysfunction and intracranial lesion, which is craniopharyngioma. So again, here CT or MRI is done to rule out what is the condition. Now, if it is very high, FSH, LH is very high, again, karyotyping is done. Usually it is chromosomal abnormality. So it is Turner syndrome, Cushing syndrome. Gonadal dysgenesis is the problem here. Okay, so this is the investigation pattern that happens in a amenorrhea case. Primary amenorrhea case. Now, diagnosis of primary amenorrhea based on clinical examination. So, patient has come. Now, how to diagnose? Now, the first one is normal breast development. The secondary sexual character is normal sexual hair, average stature. So, stature is not very short. Now, external genitalia on examination is normal. but internal genitalia is absent. Vagina is absent, uterus is absent. The probable diagnosis is this: Mayer-Rokitansky Kuster-Hauser syndrome. So this is the probable diagnosis. Again here, the second diagnosis could be everything is normal. Physical appearance is normal, external genitalia is normal, internal genitalia is normal, but still amenorrhea is there. The reason could be unresponsive endometrium, and usual condition which is associated with that is uterine synechiae. Next is poor breast development and scanty pubic hair, but stature is normal, average stature. And external genitalia on examination, there is underdevelopment of external genitalia. And again, internal genitalia is also underdeveloped, vaginal rugosity is absent. Here, the cause could be related to hypogonadotrophic hypogonadism. That means it is hypothalamus and pituitary cause. Now, the patient is very tall and lanky, but external genitalia is underdeveloped and internal genitalia also underdeveloped. Here it is primary ovarian failure. And next condition is there is poor secondary sexual character. The patient is short, webbing of neck and cubitus valgus is present, congenital malformation of cardiac, renal or great vessels, phenotypically female. The patient appears to be female, but external genitalia again underdeveloped, and then internal genitalia underdeveloped with streak gonads. So the condition here is Turner's syndrome. Next is average height is there, but there is delayed secondary sexual characters. And external genitalia again is normal. And then internal genitalia, there is bilateral streak gonads. Then that is pure gonadal dysgenesis, purely chromosomal abnormality. And now normal breast development without areolar pigmentation, scanty pubic hair and axillary hair, but stature is average, that is normal. There is labial or inguinal gonads, that is external gonads, and then short blind vagina and absence of uterus. So this is androgen insensitivity syndrome. And then normal phenotypically female, normal she is, and there is average stature, not short, not tall. But labial fusion is seen, and there is enlargement of clitoris seen, but normal internal genitalia. Here it is adrenogenital syndrome. So the problem is with adrenal gland. Next is hypogonadotrophic hypogonadism. The features of hypogonadotrophic hypogonadism is seen. That is here, these features are seen. These features are seen. Plus, along with that, the short stature, there is a mental retardation, there is obesity, and there is retinitis pigmentosa. But again, external genitalia underdeveloped and internal genitalia underdeveloped. The causes here would be cretinism due to hypothyroidism, hypothalamo-pituitary dysfunction, Kalman syndrome, Hader-Labart-Wille syndrome, Lawrence-Moon-Bardet-Biedl syndrome. So these are all related to hypothalamo-pituitary dysfunction. Now, types of amenorrhea based on investigation. So now we have sent them to hormonal assay, and then we have to see the cause. Now we see that the cause is hypergonadotrophic, but with high FSH and low estrogen levels. That is why the pathology is usually in the ovary. Now, if it is hypogonadotrophic, the FSH is usually low and estrogen level is also low. The pathology is in CNS and hypothalamus and pituitary. But eugonadotrophic, normal. That is, serum levels, FSH is low, normal, estrogen level is normal. The pathology is varied. Here, the pathology usually could be the genital tract obstruction. All those genital tract related, unresponsive endometrium related pathology could be here. Next, this finishes primary amenorrhea. Now we'll come to secondary amenorrhea. So secondary amenorrhea means she's got menses before. Suddenly she's not getting menses. Suddenly there is no menses happening. Let us see the definition. So again, there is absence of menstruation more than or for. That means more than or equal to 6 months. So if we have to call it a secondary amenorrhea, so it should be more than or for equal to 6 months. Or this is if it is regular cycle. If there is history of regular cycles. Every month she used to get cycles. Then it is 6 months. If it is irregular cycles, that means 2 months once she used to get, 3 months once she used to. Then it is 3 menstrual cycles she's not got. Continuously 3 menstrual cycles has not happened, then it is called as secondary amenorrhea. So then one important thing is she was having normal menstruation. There is history of onset of menarche was there, and then a history of normal menstrual cycles were there. Suddenly the menses has stopped. So we will see what are the causes. Etiopathogenesis. Now there are various factors for this. The first one is uterine factor. So in uterine factor, it could be tubercular endometritis, which is causing amenorrhea. Why? Because there is destruction of endometrium or inhibition of ovarian function by tubercular toxin. So when there is destruction of endometrium, obviously there is no menses. Next is prostradiation, and here also there is destruction of endometrium. Synechiae, again intrauterine adhesion. Synechiae is a condition where there is a lot of adhesions, and that is why there is amenorrhea. And surgical removal is due to ablation of endometrium by laser and resectoscope. That is why, because here the problem is with endometrium. So uterine factors usually endometrium, and that is why normal menses is not happening. Next is ovarian factors, polycystic ovarian syndrome. Very important question, which is related to exam. Most common cause for secondary amenorrhea. The maximum cases what is seen, especially in reproductive age group below 30. So the most common cause, 30-35, the most common cause is PCOS. And this is a question repeatedly asked, like how the which is the most common cause for secondary dysmenorrhea? It is endometriosis. Same way, the most common cause for secondary amenorrhea is polycystic ovarian syndrome. So what happens here? There is tonically elevated LH, and there is increased androgen. So one thing you should remember is, it like menopause is a hypoestrogenic state. Like that, in PCOS is a hyperandrogenic state. Because of high androgen, the menses is not happening. There is negative feedback mechanism, and there is estrogen is reduced. So androgen production from the theca cells, we all know ovary has something called theca cells, which is capable of producing androgens. In PCOS, it is elevated, it is high. And stroma of ovaries, SHBG is increased, unbound estrogen and androgens. Pituitary sensitivity with gonadotropin. This is all related to the positive and negative feedback mechanism of HPO axis. Gonadotropin releasing hormone is increased. Differential increase in the production of LH. So PCOS actually will be dealt as a special topic in a later part. So in other sessions. So this is just a gist of it. And production of LH, decreased production of FSH, and then due to inhibit, disturbed adrenal function is also implicated in androgen excess. A state of hyperandrogenism produce amenorrhea by its anti-estrogenic action. So just remember, there is increased androgen in PCOS, which is resulting in amenorrhea. And next is in ovarian factors, premature ovarian failure, that is absence of follicle. So premature menopause, very early menopause is a condition where it is related with premature ovarian failure. That is absence of follicle or accelerated rate of depletion of follicle in the ovaries. The ovaries, either follicle is very less, or there is no follicles at all. So what happens? This lady will get early menopause. And then resistant ovarian syndrome or Savage syndrome. Here the follicles are present, but they are unresponsive. They are resistant to gonadotrophins. We know it should be, there is defect in FSH receptor. So follicles are actually, FSH means follicle stimulating hormone. So they should be, the follicles should be responsive for the action of FSH and LH. But it is not happening, and that is why there is resistant ovarian syndrome. This is one of the cause of amenorrhea. Next is hyperestrogenic state. So there is excess estrogen. So when excess estrogen is there, again negative feedback mechanism, FSH, LH is stimulated, and again there is this mechanism happening, and then there is no menses. So persistent follicle in metropathia, the estrogen level remains high. There is estrogen should go down for few changes to happen in the endometrium so that normal menses is established, but this is not happening, and there is no fluctuation. The fluctuation of estrogen is very important in the menstrual physiology, but that is not happening, and that is why there is no menses. Next is feminizing tumor of ovary, that is granulosa cell tumor. As such, as long as endometrial support is not lost, amenorrhea continues. Here there is amenorrhea which continues because if endometrial support is lost, then there what happens? the blood is shed, the endometrium is shed. But in this condition, the endometrium is not shed properly. That is why there is amenorrhea. And then androgen excess. So the other next factor is androgen excess. In that, it is masculinizing tumor of the ovary. So we all know the theca cells, which was discussed, it has a capability of producing androgens. But there is a tumor of that part which makes it produce more androgens. If more androgens are there, then obviously there is no menses. So sertoli Leydig cell tumor, it is also called. So androgen excess opposes the effect of estrogen on the endometrium, and hence there is no menses. Next is hypoestrogenic state. So there was hyperestrogenic state, now it is hypoestrogenic state. That means estrogen is low. So both estrogen becoming low also is a problem, estrogen becoming high is also a problem. And then the cases where hypoestrogenic state is seen is oophorectomy and pelvic radiation. In oophorectomy, removal of site of production of estrogen is happening. That is why there is no menses. And then pelvic radiation makes the ovaries unresponsive to gonadotrophins. So it becomes ovaries become unresponsive due to the radiation effect. So after because of that, there is no menses. Next is pituitary factors. So there are a lot of factors in secondary amenorrhea. So next is pituitary factors. In that, adenoma, as I discussed earlier, prolactinoma. So prolactin is a hormone which is acting here. So prolactinoma, microadenoma. So prolactinoma, Cushing's disease, acromegaly. The mechanism what happens is microadenoma usually associated with hyperprolactinemia, and it either inhibits ovarian steroidogenesis directly or inhibits pituitary gonadotrophin release. So both of this, if there is inhibition in ovary or if there is inhibition in the pituitary and hypothalamus, obviously there is no menses. Next is Sheehan syndrome, a very important question for competitive exam. So this occurs in a case of postpartum, severe postpartum hemorrhage. So what happens because of severe postpartum hemorrhage and there is a shock? What happens due to venous thrombosis? There is ischemia of the pituitary. So of the pituitary gland, and there is partial or complete destruction of the pituitary. So here the pituitary gland is destroyed, and that is why there is no menses. So, but the cause here, you have to remember, is postpartum hemorrhage. PPH is the cause for Sheehan's syndrome. Whereas there is something called Simon's disease, where the same thing happens. That is, there is destruction of pituitary that is related to congenital cause. It is not related to the pregnancy. Here in Simon's disease, there is partial or complete destruction of ovary, but it is not related to pregnancy. It is not related to postpartum hemorrhage. The one condition where postpartum hemorrhage plays a role is Sheehan's syndrome. And the primary hormones affect our growth hormone because pituitary is destroyed. So growth hormone, gonadotrophins, TSH, adrenocorticotrophins, and prolactin, all these hormones are disturbed or affected. That is why menses is not happening. So this finishes the pituitary factors. Next is thyroid factors. So if there is hypothyroidism, what happens? Raised TSH and hyperprolactinemia by direct action of thyroid releasing hormone on the galactophore cells in the pituitary. So this here, what happens? Because of hypothyroidism, it acts on the pituitary again, and then there is problem with release of pituitary hormones necessary to stimulate the ovaries for estrogen and progesterone. That is why there is no menses. General disease like malnutrition, tuberculosis, chronic nephritis, diabetes mellitus, juvenile diabetes mellitus especially, what happens? Again, these are affecting, probably, the exact mechanism is not known, probably it could be, it is affecting the hypothalamo-pituitary ovarian axis, and that is why there is no menses. Next is a lot of factors are there. So next is hypothalamic factors, an important factor. So here, the psychogenic shock, stress. Stress is an important factor. Anorexia nervosa, as I was discussing, the weight is an important factor to diagnose what is the cause behind the amenorrhea. So anorexia nervosa, there is excess weight loss, and the other thing is strenuous exercise. Again, excess weight loss, pseudocyesis, false pregnancy. So all these are hypothalamic factors. The mechanism behind this is inhibition of release of gonadotropin releasing hormone or affect the dopamine metabolism. So if dopamine metabolism is affected, then there is low level of estrogen and LH, but FSH level remains normal here in hypothalamic factors. So the hormones which are responsible, it is here estrogen and LH. Next, congenital malformation. Again, this is also related to hypothalamic factors, and trauma, accident, surgery or radiotherapy, infection, tubercular or sarcoid granuloma, tumors like craniopharyngioma and meningioma. What happens? It leads to hypogonadotrophic hypogonadism. There may be hyperprolactinemia due to altered dopamine inhibition. Again, here dopamine, and tumors of hypothalamus or pituitary need surgical excision or radiotherapy. Only then the correction here is surgical or radiotherapy. These are the hypothalamic factors. Next, adrenal factors is adrenal tumor or hyperplasia or Cushing syndrome. So here there is androgen excess because adrenal gland there is a tumor and opposes the effect of estrogen on the endometrium, which inhibits the menses to occur. Now, iatrogenic causes are contraceptive pills. So there is something called post-pill amenorrhea. So after the pill is taken, there is no menses. So even when the pill is withdrawn, and then the lady is waiting for the menses to happen, but it is not happening. So that is something called post-pill amenorrhea. So and then psychotropic drugs, antihypertensive drugs. These all have effect on the gonads, so that there is no menses. So this completes the factors, etiopathogenesis of secondary amenorrhea. I know it's very lengthy, but these are the important factors. Next is common causes for secondary amenorrhea. It is hypothalamus, it is stress, post-pill amenorrhea, weight, and drugs. In pituitary, the common causes adenoma and Sheehan syndrome. So exam point of view, Sheehan syndrome is important, and then PCOS is important. PCOS is the most common cause for secondary amenorrhea. Premature ovarian failure in ovary causes, uterine causes synecia, and systemic causes malnutrition, hypothyroid state, and then diabetes. So these are the common causes of secondary amenorrhea, which is a gist from the previous slides. Next, investigation of secondary amenorrhea. Now, how will you investigate a secondary amenorrhea case? What we saw earlier was a primary amenorrhea, where we discussed about secondary sexual characters is the most important thing. Now, here in secondary amenorrhea, first thing, if a lady is coming with secondary amenorrhea who had normal cycles, you should exclude pregnancy. This is the first common thing that we have to do. So exclude pregnancy. Now she's not pregnant. It is evident that she's not pregnant. Now we will estimate for serum estradiol, TSH, prolactin. Hormonal assay is done, and CT or MRI is done in case of Sella-Turcica syndrome. There is something called Sella-Turcica syndrome that will do. Now, if it is normal, the hormonal assay is normal. Then progesterone challenge test is done, and in that withdrawal bleeding is present after progesterone challenge. That means progesterone pills are given and then it waited, and withdrawal bleeding is present. Once it is stopped, there is withdrawal bleeding, and that means HPO axis is intact. That means hypothalamo-pituitary ovarian axis is reacting properly, normally to the progesterone. And then there is adequate endogenous estrogen, and serum estrogen also is normal. FSH, LH estimation is done after that. And if LH is more than 10 and LH to FSH ratio is more than 3, pelvic USG is done. And if it is seen that the follicles in the ovary are more than 10 and there is hyperandrogenemia, then it is PCOS. This is how PCOS is actually diagnosed. But what we usually do, send for directly to USG. That is how it is done. But actually, the progesterone challenge test is done, then estrogen is evaluated, then FSH-LH ratio is evaluated. And if it is seen in USG that more than 10 follicles are there, then it is PCOS. And PCOS has a criteria for diagnosis. Diagnostic criteria is there. It is not only USG. There are a lot of criteria for us to tell that this is a PCOS case. So that will be dealt in PCOS separately. So in the next sessions. Next, after withdrawal bleeding is absent. Now after progesterone challenge test, withdrawal bleeding is not there. So loss of progesterone receptor, diseased endometrium. Now endometrium is not responsive here. So estrogen progesterone challenge test. Again, next is estrogen progesterone. Now progesterone is done. Now we will see for estrogen. So in estrogen progesterone, there is no bleeding here. The non-functioning endometrium. Endometrium is completely non-functional. Uterine synecia is there. Now HSG is done. Hysteroscopy is done to confirm or rule out synecia. If bleeding occurs with estrogen progesterone challenge test, then endometrium is responsive, but estrogen is low. Estrogen is low. Then we will have to see what is the FSH and LH ratio or LH levels. And if FSH is high, more than 30, then there is ovarian failure, resistant ovarian syndrome. And if it is less than 25 years, again, karyotyping should be done. In karyotyping, we have to see what is the problem with the chromosomal pattern. And if it is more than 25 years, ANA, TSH, and antithyroid abnormalities should be seen. Antithyroid antibody should be seen for thyroid evaluation. And then lower normal, FSH is lower normal. If it is less than, LH is less than 5 milli international per ml, hypothalamic or pituitary lesion or dysfunction or failure, it is a result of HP. Here O is not there, and CT MRI is done to know what lesion is there in the hypothalamus and pituitary. And if there is lesion, then surgery. If there is no lesion, multidisciplinary approach means surgeon also comes here, gynecologist also comes here, and a radiotherapist, a radiologist also comes here. So there are 3 people who will be involving in this surgery, because all the 3 are important here. And then low lesion, there is no lesion, then it is gonadotrophic releasing hormone dynamic test is done. If positive, negative, it is seen. Now, this here, TSH, when serum estradiol, TSH, and prolactin is seen, that it is now, if it is normal, this procedure is done. If it is abnormal, TSH is high, prolactin is high, cellular turcica syndrome, abnormal cellular turcica, then it is hypothyroidism and pituitary adenoma. A lesion is found, it is pituitary adenoma, surgery is suggested. So this completes amenorrhea. Next, we come to the contraception. So what is contraception? Why is the need for contraception? So contra means opposite. Conception means the conception. That means giving birth. So contra means avoiding that. So what are the methods for that? Let us see. So definition is all measures temporary. Contraceptive measures can be temporary or permanent. So designed to prevent pregnancy due to coital action. And the ideal contraceptive method. So what are the qualities for an ideal contraceptive method? First one, it should be highly effective, 100% effective. But there are no there is no contraceptive method that is 100% effective altogether, except for permanent methods. So there are no temporary methods which is highly 100% effective. And then it should be acceptable. The lady or the man or the female, male or the female should be able to accept by them. It should be acceptable. Next, it should be safe. And it should be reversible. So even the permanent methods, whatever it is done, it should be reversible. It should not be a permanent thing for lifelong. And then it should be cheap. And then having non-contraceptive benefits. It should serve the purpose. It should have, if it is a contraceptive, it should serve as a contraceptive. And then it is simple to use. And requiring minimal motivation, maintenance, and supervision. This is the qualities for an ideal contraceptive measure. Now, what are the types of methods of contraception? So, temporary methods and permanent methods. In temporary methods, it is barrier method, natural contraception, IUCDs, and steroidal contraception. In permanent methods, it is for female tubal occlusion. The most common thing is done as tubectomy, as you all know, and male, it is vasectomy. So, quickly we'll see what it is. So, which is the effective contraceptive method according to WHO? So again, the question is there for you. IUD. The options will have, most commonly it is about IUDs. So IUDs is the most effective method. So along with that, sterilization and implants. These are the most common effective method, contraceptive method. And next is injectables. LAM is lactational amenorrhea, and contraceptive pills and progesterone pills, oral pills, patch, vaginal rings. These are very effective. Male condoms, diaphragm, female condoms. These are barrier methods. Fertility awareness methods. These are okay, effective. And spermicides is less effective. And withdrawal method. There is something called withdrawal method which is practiced, but WHO has not given a category for that. So this should be, as a doctor, we should be able to explain the patient that this is not even a method of contraception. Whatever they are adopting as a contraceptive method, we should be able to guide and counsel the patient that it is not even a proper method to be followed. Next is temporary method, barrier method. It prevents, the purpose here is what it does. It prevents the sperm deposition in the vagina, and it prevents sperm penetration through the cervical canal. The types of barrier methods are mechanical. For males, mechanical methods, chemical methods, and combination. Combination is both mechanical and chemical. For males, mechanical method is condoms, and for females, there are three: condom, cervical cap, and diaphragm. Next is chemical methods. These are usually for the females. It is vaginal contraceptives, which is applied locally. So creams, defen cream, jelly, Coromex, and Walper paste, foam tablets, aerosol forms, a tea or contact sponge, and then combination is mechanical with chemical. That means they can use a cervical cap along with creams. So this is combination methods. Next is natural contraception. So this usually it is with the caution you have to counsel the couple. So rhythm method, there is something called rhythm method. The natural contraception means they're not using anything. They're just naturally there are few conditions where the conception is not happening. So in rhythm method, the fertile period is identified. If the lady is having a regular cycles, monthly cycles, the fertile period of a cycle is identified and abstained from sexual intercourse. That means during ovulation, there is no sexual intercourse, so that there is no after ovulation, so that there is no fertilization happening, and that is why during fertile period there is abstinence from sexual intercourse, and this is a rhythm method. It is also called as calendar method. That means the fertile period is marked in the calendar and then it is followed. And then coitus interruptus. This is withdrawal method, which was in the WHO category. It was not at all there. So here, what is happening? Withdrawal of penis shortly before ejaculation. And then breastfeeding and lactational amenorrhea. So when I was discussing lactation, amenorrhea, in physiological amenorrhea, lactation is one cause for amenorrhea. So here, this also, the couple should be counseled that lactational amenorrhea is not a contraceptive, 100% effective contraceptive method. Next is IUCDs, very important. So these are safe, effective, and reversible method of contraception. They are bioactive, hormonally active. And then types are copper T 380. Just remember this, 380. Commonly asked question, because in earlier copper T7, this number they use. Now the prevalent one is copper T 380. So it can be asked as 340, 360, whatever it is. So just remember 380. And then multi-load 375. And then LNG, that is levonorgestrel intrauterine system. Levonorgestrel intrauterine system, LNG I use. These are the common IUCDs used now as Skyla. These are the 4 common IUCDs used usually. Next is time of insertion. This is very important question. For any contraceptive, time of insertion is important. It is a frequently asked question. So the interval when the insertion is made in the interconceptional period, that means their normal intercourse is happening beyond 6 weeks following childbirth. After childbirth and abortion after 6 weeks, when can the insertion be made? 2 to 3 days after the conceptional period. Menstrual cycle, anytime it can be done. Insertion, that is IUCD. Most common is copper T. So copper T insertion can be done anytime. And in lactational amenorrhea, when the lady is breastfeeding, then also anytime it can be inserted. And in post-abortion, immediately it can be inserted. And in postpartum, that means after delivery, post-placental. Yeah, after the delivery of placenta, within 10 minutes after expulsion of placenta, following vaginal delivery, copper T can be inserted. Intercesarean, during C-section, when it can be inserted, it can be after the removal of placenta. The placenta is removed, the baby is removed, taken out, and the placenta is removed. And after that, before the closure of incision, the insertion of copper T can be done. And within 48 hours of delivery, before patient's discharge, also it can be inserted. And this is an important question. Extended postpartum, normally after the postpartum, when it can be inserted, it is 6 weeks. 6 weeks, you have to remember. 6 weeks after the postpartum is the normal period for insertion of copper T. If it is not done within 48 hours of delivery, then anytime after 6 weeks, it can be done. Next, contraindications. Again, contraindications is important for any contraception method. So suspected pregnancy or pregnancy, it is not to be put. Undiagnosed genital tract bleeding is there. First diagnose the bleeding, then know what is the cause, treat it, and then insert the copper T. And then acute pelvic infection, current or within 3 months, the lady has had very acute infections, then pelvic infections, then not to be inserted. And distortion of shape of uterine cavity, as in fibroid, congenital uterine malformations, no, it is a contraindication. Severe dysmenorrhea, not to be inserted, because when the insertion is happening, there are few complications like cramping pains. So dysmenorrhea is in severe dysmenorrhea if it is inserted, because dysmenorrhea is a case where there is what is it, the muscles, uterine muscles are not stable, so that is why insertion shouldn't be done during that time. Known or suspected uterine or cervical neoplasia, any cancerous condition, no insertion should be done. Postpartum or post-abortal endometritis, there is inflammation of endometrium in the last 3 months, or infected abortion, after abortion there is infection followed by abortion, it shouldn't be inserted. And sexually transmitted diseases, current or within 3 months, if it is there, it shouldn't be inserted. Trophoblastic diseases, significant immunosuppression, the patient doesn't have immunity, enough immunity, then it shouldn't be inserted. These are the contraindications. And for copper T contraindications, this is also a frequently asked question. Copper T contraindications, what are the what is the main contraindication? It is Wilson's disease and copper allergy, because Wilson's disease also is a condition due to the copper. So it is contraindication. And for levonorgestrel intrauterine system contraindication, it is hepatic tumor or hepatocellular disease. It is related with the liver. And then current breast cancer and severe arterial disease. These are the contraindications. Now, complications of IUCDs. Immediate complications is cramp-like pain. That is why severe dysmenorrhea, it is not to be inserted. Syncopal attack, there is sudden syncope, and then partial or complete perforation during the insertion. And remote complication. That means after insertion, after a period of time, there are complications. They are pain and abnormal menstrual bleeding, and this can be hypomenorrhea, amenorrhea. That means even after removal of the copper T or the IUCD, there is amenorrhea. And then intermenstrual discharge, that is happening, that can be one reason. And then PID, pelvic inflammatory disease. So pelvic inflammatory disease also, it is a remote complication. And then spontaneous expulsion. Suddenly the IUCD is expulsed. So that is one of the complication, and perforation of uterus is one of the complication. Next, indications for removal. When all you can remove this, when copper T is inserted, and then when all you can remove. Persistent, excessive, regular or irregular uterine bleeding, and flaring up salpingitis, that is fallopian tube inflammation, perforation of uterus. IUD has come out of place. There is partial expulsion, not complete expulsion, then it should be removed. Pregnancy occurring with the device inside too. Even with the presence of device, the pregnancy is occurring. That is why IUCD is not 100% effective contraception. Pregnancy can occur. And women desirous of a baby, women want to have a baby. And IUCD, as we told in the first, in the introduction part, it is a reversible contraception method. And if she wants to have a baby again, then it can be removed. And then missing thread. So there is something called, if the copper T is like that, there is something called thread. And after the insertion, the women is advised always to look for this thread. So if this thread is missing, then it means it is gone inside. That means it is displaced from the endometrium, and implantation is not the implantation, whatever it is done, it is displaced. That is why immediately the lady is advised to go and consult the gynecologist so that she can remove the IUCD. And 1 year after menopause. So after menopause is a physiologically contraception. So after 1 year is waited for after the menopause, and then it is removed. And when effective lifespan of the disease is over, so every IUCD will have 10 years, 12 years, 13 years. So when that is over, it is removed, and again a new one is inserted. These are the removal for indications for removal. Next is steroidal contraceptives. Here it is oral contraceptives, OCPs, what we know, the oral contraceptive pills, and parenteral devices and patches. In OCPs, it is combined preparations, monophasic, biphasic, triphasic. So, and in oral single preparation, it is progesterone only pill. It is called mini pill, and estrogen only is the emergency pill. So, immediately after the post-coition pill, it is emergency pill is estrogen, and parenteral injectable is DMPA, net N and combined, and implant is Implanon, Norplant, and LNG rod. Devices is IUD, it is LNG IUS, that means levonorgestrel intrauterine system. Vaginal rings are LNG ring, combined rings of estrogen and progesterone, and transcervical is Essure and Adiana, and patches is transdermal patches. So these are the steroidal contraceptives. So indications for indications and contraindications. So the main part in this is the contraindications. So the contraindications is relative contraindications. You can just go through the absolute contraindications. These are very important because this will be a question for AIPGT or any other competitive examination. Is the absolute contraindications for contraceptive pills. It is circulatory diseases. Past or present arterial or venous thrombosis, severe hypertension, history of stroke, heart diseases, diabetes and vascular complications, migraine with focal neurological symptoms. So a question can be prepared along with the relative contraindication and ask that which is the absolute contraindication. So you should be very careful which is a relative contraindication and absolute contraindication for contraceptive pills. And diseases of liver is there is active liver disease in jaundice, liver adenoma and carcinoma. Others are absolute contraindications are pregnancy, breastfeeding, that is for 6 weeks, and major surgery or prolonged immobilization, estrogen dependent neoplasm, that is breast cancer. So these are the absolute contraindications. Next, indications for withdrawal. When this can be withdrawn, it is severe migraine, visual or speech disturbance, sudden chest pain, unexplained fainting attack or acute vertigo, and severe cramps and pains in legs, excessive weight gain, severe depression prior to surgery, any surgery if it is conducted. The pill is withdrawn, and a patient wanting pregnancy, then it is withdrawn. Complications of this OCPs, minor and major. The minor complications are nausea, vomiting, headache, leg cramps, mastalgia, breast pain, and weight gain, plasma and acne, menstrual abnormalities. Again, with OCPs, there is metrorrhagia, hypomenorrhea, and amenorrhea. Here also, post-pill amenorrhea is also seen, and libido is diminished, reduced sexual desire, and leukorrhea, white discharge per vagina. And then major complication is depression, because it is a hypoestrogenic state, and there is complete hormonal withdrawal. So that is there is what to say, the normal physiology is disturbed completely, estrogen and progesterone with the pill. So there is artificial pill that is going on in the body. That is why there is the effect is on the hypothalamo-pituitary ovarian axis. So depression is there. Vascular causes are venous thromboembolism and arterial thrombosis. So venous thromboembolism is a common complication of a OCP, and cholestatic jaundice, neoplastic risk. Also with this OCPs, there are few benefits. Neoplastic benefits are also seen, that few types of cancers are not seen when OCP is taken, and the death risk is among 1 lakh women, only 1.5. It is seen that there is a death. So the death risk is usually low with OCP. Next, as you can see, it is male sterilization vasectomy, female sterilization tubal ligation or tubectomy, and it is a permanent sterilization method. So we'll see one by one. Male sterilization vasectomy, it is a segment of vas deferens. So here you can see in the picture, the vas deferens on both the sides. Of both the sides are resected, cut, and the cut end is ligated. Okay, so selection of candidates usually is sexually active and psychologically adjusted husband having the desired number of children. So this is the ideal category of people who can go for vasectomy. Next, female sterilization tubectomy, it is occlusion of fallopian tubes. So fallopian tube, so that the fertilized, after fertilization, so that the fertilized product cannot enter the uterine cavity. So to prevent that, the fallopian tube is ligated. And the most popular method for terminal contraception. So which is the most popular method for terminal contraception all over the world? It is tubectomy or female sterilization. Indications is family planning. She doesn't want to have the baby now. She wants to have it a few years later, or whatever the decision. Then for that, it is one of the indication. Socioeconomic status is very poor. She cannot afford to have more children. Then it is one of the indication. Medico-surgical, like there is some what to say. Conditions where pregnancy can cause a complication if the surgery happens, and after that if pregnancy is happening, then it is a complication for the female. So in that case, the tubectomy is done. And risk reducing self-injectomy, here also tubectomy is done. Next, time of operation. This is also very important. And ideal is following menstrual period. Normal menstrual cycles a female is having. Proliferative phase, during proliferative phase is the ideal time for the tubectomy to be done. And 3 months after delivery or abortion. So if she has had a child and then, or she has undergone an abortion. So after 3 months, only after 3 months, she can go for tubectomy. But whereas IUCD insertion is after 6 weeks. Just remember. And then MTP, that is if there is a medical termination of pregnancy that has been done, and it immediately also it is done along with the MTP, and LSC is also along with the MTP, along with termination, the tubectomy is done together, and LSCS also along with LSCS. It is done together with the LSCS, the tubectomy is done. But important is prior consent. So consent is taken and then done. Next, tubectomy, the methods of doing it is abdominal, in that conventional method, or mini laparotomy, so laparoscopy, and vaginal tubectomy. Now, abdominal and vaginal, the surgery can be performed by anyone conversant with surgery, abdominal approach. Time of operation can be done anytime, puerperial or interval. Contraindication practically nil. Uterus less than 12 weeks size. It can be done. Anesthesia can be done under local anesthesia, abdominal approach, and complication easy to tackle. Duration of operation is shorter. Complications, immediate complications is wound infection, peritonitis is rare, and late complication is incisional hernia. Failure rate is less. And then hospital stay is longer in abdominal approach and shorter with mini laparotomy. Whereas vaginal approach can be done by a surgeon conversant with vaginal plastic operation. And interval period is most suited, may be done in other time, provided uterus is smaller than 12 weeks, and associated tubo-ovarian mass and uterus, tubo-ovarian mass and mass in uterus more than 12 weeks, it is a contraindication. And general or spinal anesthesia is usually needed. Local anesthesia will not work here. Difficult at times of laparotomy. Difficult at times of laparotomy may be necessary along with vaginal approach, and the duration is longer, and complications are hemorrhage, revealed or broad ligament hematoma, and injury to the rectum. Late complication is dyspareunia. And failure rate is more in vaginal approach. It is shorter, 24 to 48 hours, the lady is discharged. So this completes contraception and amenorrhea. So you can just go through and know which are the important questions by going through the question papers, which are the repeated questions. Both the topics are important in its own way.